Hello and welcome to Individualizing Management Plans for Type 2 Diabetes through Shared Decision Making and Office Hours Activity. My name is Lucia Novak, and I am the president of Diabesity LLC and the co-executive director of Capital Health and Metabolic Center of the Capital Diabetes and Endocrine Associates located in Maryland. Thank you to Peerview for providing the session and to Lily for providing the educational grant for this activity. Throughout the presentation, please watch for additional follow-up polling, and you can submit your questions using the chat feature. I will be answering them live in the chat during the first 30 minutes of the program and live on your screen for the office hours portion in the second 30 minutes. You can view and download today's slides as well as the helpful practice aids on the Peerview website. So before we move on, please take a moment to answer a question on your current approach to shared decision making. So today's webcast was designed to fill gaps exposed by other recent continuing education activities on type 2 diabetes and weight management. And here's what we noticed about primary care clinicians' responses to some questions about initiating discussions for both type 2 and weight and using the shared decision-making process. While many of you answered questions correctly, we did see that some of you were unsure of your answers, maybe due to lack of confidence or just not enough information or knowledge. But we also identified some that were answered incorrectly. For instance, narrowly focused on clinical endpoints rather than the broader clinical context. For instance, you're looking at their hemoglobin A1C, and maybe you weren't realizing that a medication could also be really good to reduce the risk for a heart event or for heart failure, something along those lines. That you really weren't using shared decision making all that much, and you're more likely to rely on personal experience rather than the clinical evidence or the science backed evidence that we use when we're practicing. So therefore, our goals for today, we're going to initiate discussions about weight management and treatment intensification with people with type 2 diabetes who also have overweight or obesity. And hopefully, we will be able to equip you with strategies that will utilize shared decision making and help you to develop those individualized care plans. Starting the conversation. So what we're looking at here on this slide are the ADA, or the American Diabetes Association guidelines, that show that shared decision making is actually an important part, an essential part of developing that person-centered care plan that everyone speaks of when we're trying to help manage type 2 diabetes and actually any chronic disease that our patients might have. And as you can see, it goes around in a circle, and it starts with addressing the patient's key characteristics, thinking about specific factors that might impact your decision as to what treatment the patient may need, but then also using the information you gather from the patient to create a dialogue, a shared decision process where you can both then agree on a plan, implement that plan, provide ongoing support for the patient as they try to continue to implement, and then determining at a follow-up appointment somewhere down the line whether or not the plan that you both agreed on is working and do we need to make any tweaks. So for today's talk, we're going to be focusing on the blue box that identifies utilizing the shared decision making to create that management plan. And when we look at the details that are involved with shared decision making, one of those things is making sure our patients have access to diabetes education and support. So DSMES stands for Diabetes Self-Management Education and Support. And so making sure our patients have access to certified diabetes care and education specialists, certified classes for diabetes education, and registered dietitians who can provide medical nutrition therapy support for our patients. that's just the baseline of what they would need so that they can better participate in the shared decision making with you. And then, of course, we're going to involve not just the patient themselves, but if they bring someone with them to that appointment, a support person, we want to include them as well. And I encourage my patients that if they live with someone or have someone that they rely on to assist them with their activities of daily living or medication taking, that they include that person, invite them to join us, because you could always use an extra set of eyes and ears at an appointment. And then, of course, we're going to explore what the patient understands, what their preferences are, and how we communicate to the patient. Also, want to make sure that we don't call them a diabetic or that they are obese. We want to use patient-centered or patient-focused language. So it would be you have diabetes or you also have the disease of obesity. It kind of gives the person their autonomy and it doesn't assign them a diagnosis as to who they are. And that really does matter. And then talking at the last bullet about motivational interviewing. And I think when people hear motivational interviewing, the eyes just kind of roll back, because we understand that while it is important to do motivational interviewing to involve the patient in the decision process, it's probably a skill that many of us don't use very often. We may not be comfortable with, and we're probably thinking, oh my goodness, I don't have the time. So hopefully I can share with you how I practice, and maybe it can help make it seem less intimidating for you and the patients as well. We know that shared decision making works. So it would not be included as a recommendation in the American Diabetes Association guidelines if there wasn't some research behind it to show that it actually does work. And so this is just one of many studies that looked at shared decision making in a population that have type 2 diabetes. And what we found is that about 38% of the patients that were polled in this particular study perceived that they had some degree of shared decision making with their clinicians. And less shared decision making was associated with the person being older, being male gender, or uninsured. And so, again, we want to try to bring these numbers up because we have seen that when shared decision making is at a higher level or a higher perceived level, there is an increased satisfaction with care. And when patients are satisfied with their care and they feel that they are being included and adequately addressed, them and their needs, they tend to be more open with us. And as a result, we get further with them when we're trying to accomplish certain goals. Shared decision making was not necessarily associated with medication adherence, but it could be just the way that that was measured. I have seen other studies where we have seen a drop in hemoglobin A1C, as well as improvement in depression scores, as well as diabetes distress with patients who feel that they have an open dialogue with their healthcare provider and that they feel that their questions and their concerns were included in the development of the plan. So while we know it's important, it's obviously included in the guidelines. We have data that supports that it is very effective. What's probably missing for most of us clinicians is that there really isn't much guidance on how to involve patients in the shared decision-making process. And so the Mayo Clinic probably has done most of the research that is involved with shared decision making. And they have come up with three approaches. One is to share that information. So, again, and that's a two-way street, the patient sharing the information about themselves once they understand what we are working toward. You know, does what we are presenting to them work in their life? And we are also sharing the information about what the disease process is. what we are trying to help them accomplish and what therapies are going to be needed to accomplish those goals. The second approach would be patient choice. And so I I proceed with caution here because yes, their patients always have a choice, and no choice is also an option if they choose not to do anything. What our responsibility is to make sure that they are making an informed choice. So if you think of shared decision making almost like informed consent, then you will have a better understanding of what the shared decision making process is. They need to know what the results are of their actions as well as inaction, and what are the realistic options that are available to them. And then they can make a choice. Of course, the third approach is having a conversation. And to me, that would include both sharing the information as well as understanding what the patient's choices are and why their choices may be that way. Before we move on, please take a moment to answer a poll on patient attitudes towards shared decision making. So let's first introduce a case, and this is a woman that is 57 years old, and her name is Anna. She is newly diagnosed with type 2 diabetes, and you saw her for the first time about a month ago. At her diagnosis, her A1C was 8.9%. And at her initial visit, you referred her to diabetes education as well as a registered dietitian to help her with her lifestyle changes that were needed to better manage her diabetes as well as improve her overall health. She did indeed attend the classes and has met individually with a registered dietitian for her medical nutrition therapy. And she has found that using the plate method has been a simple as well as effective way to help her with making appropriate portions and also working on decreasing her intake of ultra processed foods. She is now walking twice weekly for at least 20 minutes, and she wasn't doing that at that initial visit. So now we need to get Anna talking about how she feels that she is doing and what we think needs to be done better. And I will tell you that a patient's ability to want to participate in the shared decision making process is really going to depend not on just how much knowledge they have, but how much perceived power or capacity that they can bring to the appointment. Is their opinion taken seriously? Do they value their own opinion, or are they deferring primarily to what you're telling them to do? So, our goal is to help our patients feel empowered in that encounter so that they can be involved. But there are things that get in the way. And some of the things come from the healthcare provider side as well as from the patient side. So, what I have found, especially in diseases where lifestyle modifications are a significant part of the therapeutic plan, whether that be type 2 diabetes or overweight or obesity management, we have some inherent biases. We're human. We're going to bring those biases to every appointment we have with our patients. It's important that we understand what our biases are because they will translate. And oftentimes, if we're not aware of them, they will not be in relation to what words we are saying, because our body language and other things will convey a different message to the patient. So we want to make sure that we understand what our limitations are and that we address them. You can't get rid of your biases, but you can address your biases, and you can tone the language and change some things about yourself that will actually bring the patient into that empowerment phase and participate in the shared decision making. And as I mentioned, the patient also brings some baggage with them. And oftentimes, what I have come to appreciate, it's not just whether or not they have an income that can afford the medications or afford the appointments, although that is rather significant. But our patients aren't just people with diabetes. They are patients with a full life. And there are so many other things that can get in the way. And if you look at just the cost of receiving care for diabetes, 20% of it is spent on just getting access to us. That doesn't talk about the medications and so on. But they have families and they work and they may be in school, and there's all these competing priorities that sometimes overwhelm the patient and will limit their ability to successfully implement a plan we may have discussed, or from participating in the appointment in general. They may be um, ashamed, they may be embarrassed, or they just might feel like they just don't know how to even begin to talk to us about what's going on in their life. So there are some ways to kind of bring that information to them. And so this slide is showing you from the bottom up. So we would start by engaging the patient. And that again is not just by the words we say, it's also by our nonverbal communication. And that would include making sure that the seating in your office is accommodating for people who do have overweight or obesity, that they feel comfortable coming into your office and sitting down. And then using your body language where you're making eye contact and you're leaning forward and listening. And the other piece of that is also if you ask them a question, and hopefully an open-ended one that they are going to need to think and give you the information that you're looking for, that you pause long enough, because sometimes this might be the first time someone has actually asked them about what's going on in their life in a clinical appointment office. And so don't be in a rush to fill in the dead space of no talking. Allow the patient to process your question and then give them time to answer. I like to use the acronym WAIT, or W for why, A for am, I for I, and T for talking. Why am I talking? Let the patient fill in the void with the question that you have posed them. The next step would then be focusing. I like to ask my patients when they come into the office with me, was there anything specific that they really needed to address today before they leave my office? I may have a whole different plan in mind, but I have come to really appreciate that when patients feel that whatever need they had got addressed, even if I did not get to some of the things I felt were important, they leave my office feeling very satisfied, very heard, very listened to, and they're more likely to come back for their next follow-up appointment and will continue to be engaged. So again, trying to develop an agenda with the patient. They may have some things they want to address, and you can say, okay, and I have some things that I also want to make sure we cover today. So let's get to it. And then, of course, comes evoking, making sure that you are helping the patient to bring forth whatever information you need. And that could be by finding something positive that is going on in their life. So, they haven't taken their medication, they haven't done walking, their diet hasn't been the best because it's the holiday. And I say to them, but you're here today. And that is huge, because they could have chosen not to keep the appointment, as often happens when patients feel that they have not kept their end of the bargain. So I'm always looking for something positive to kind of reassure them that I am on their side with them. And I recognize the difficulty of trying to manage more than one chronic disease. Diabetes seldom comes by itself. There's usually the buy one, get three free, hypertension, dyslipidemia, weight, and then the complications of the weight. They may have bad knees, a bad back, they have sleep apnea, so on and so forth. And again, this is just a piece of who they are. There is so much more to their lives. So trying to get them to talk to us is going to be really important. And then the last thing is, once we've gotten them talking and we've identified some things that are important to them, we have relayed the things that are important to us as far as their management, then we can come together and determine a plan that we both feel comfortable with and that the patient feels able to put into place. So the four skills are going to be Open-ended questions, which I mentioned, those affirmations, again, trying to find something positive about what the patient has succeeded with since their last appointment, even if it is just coming in today when they felt that everything was just lost since the last appointment. And then, of course, the reflective listening, validating what they have to say. Oh my goodness, I can only imagine how hard this is for you. You have so many medications that you have to pay for, and you're on a limited income. So let's see if we can't figure out how to better address this. Again, you're listening to them. I see that this upsets you, and you know what? I understand why you're upset. Those are huge, validating the patient, what they're feeling. And then summarizing what they have said. This is what I'm understanding is the issue. These are your concerns. Please let me know if I've misheard you. And then also inviting them to summarize what they have understood from you to have said, so that you can clarify if there was anything. When we talk about obesity management in specific, because it is such a high stigma associated chronic disease, we are actually encouraged, and Medicare wants to see this documented in the chart, that you are using the 5 A's when talking about sensitive subjects, and that includes when you're discussing somebody's weight. And so we would be asking for permission. That's something that seems strange. We don't ask permission to discuss their blood pressure or their cholesterol. They're in our office. We assume they are here for our help. But when it comes to a stigmatizing type of disorder, we do want to ask their permission, because maybe they don't want to talk about it. And what we need to do is at least open the door. We're asking their permission, letting them know that they have the ability to participate in this conversation or not. If they're wanting to talk about it that day, then we let them have at it, correct? Like, we go ahead, tell me what's going on and what you've done that worked and what hasn't worked and what can we try to do better. But if they say, you know what, today's not the day, I just am not ready to talk about my weight, and you can then say, okay, I just want you to know when you're ready, I'm here and we can talk about some things that we can do together, and leave it at that. And I have found that patients will come back and be ready to have those conversations. We are also overwhelmed as healthcare clinicians on different goals that we need to help achieve with our patients. So, what exactly are we looking at? Are we looking at improving their diabetes? Are we looking at reducing their weight? Is it their blood pressure? Is it their cholesterol? So, a lot of competing, again, priorities, but oftentimes they're so often interwoven that if we can address one, we typically do a really good job with addressing the others. And this slide is showing you an example of therapy that we can use that can do that. So certain medications, and you're seeing here a pattern of the GLP-1s and the SGLT2 inhibitors that will help reduce that atherosclerotic cardiovascular disease risk, help improve glucose as well, and not necessarily increase weight for our patients, hopefully helping them to lose weight. So, it's important that we give this information to the patient, that there's a potential that using one or perhaps maybe two drugs, we'd be able to hit many things. What I like about this particular slide is it helps set the stage for when we're talking about weight loss with our patients. People with type 2 diabetes do not lose as much weight as those without diabetes on the same exact treatments that we use for obesity management. And what this slide is showing you is the average weight loss that you can expect when taking these medications. So patients, they seem to think that if I start this drug, I'm going to lose 50 pounds. And that's not necessarily going to be true. Everyone responds to these differently, but this gives us an idea of about how much weight we can at least expect a patient to lose, and then what else we might need to do to help the patients accomplish those goals. And it could be combining agents, it could be referring them for a bariatric procedure, all of those things. So before we move on, please take a moment to answer a poll on goal setting in type 2 diabetes. So when I have a patient that is not comfortable with intensifying treatment or wanting to use a medication, especially when it comes to type 2 diabetes, I will bring up the ominous octet. And the name is going to be changing to Noxious 9. And I think Dr. Stan Schwartz actually has an egregious 11. We keep finding reasons, pathological reasons for hyperglycemia. And the reason I bring this slide up with my patients is to show them there is not a mouth and there is not a foot on this particular slide. And it's not that the lifestyle as well as what they're eating and what they're drinking are not important. I'm trying to focus this less on the shame and blame that often is tied to nutrition and physical activity, and more on the disease process. And just based on this slide alone, there are 8 things outside of how much exercise a person does and what a person eats that contribute to that hyperglycemia. And that is going to set the stage to help me to help them understand why a medication is needed. And patients really do want to know what to expect from a medication, not only the side effects, but I often get, am I going to need to take this for the rest of my life? And I tell my patients, my goal is that you live a very full life with very few complications and on the lowest dose of medication that you would need. So it's going to depend on many things, on what type of medicine and how long they would need it. And again, we as clinicians need to be comfortable with the medications that are available and how to prescribe them and what side effects to counsel the patient on to expect. What I love about this slide is that just as if a patient were on blood pressure medicine and they decided, oh, your blood pressure is at goal, let's stop the blood pressure medication. You don't seem to need it anymore. What we would see is their blood pressure would rise and their hypertension would no longer be adequately addressed. And that is true for just about any disease, to include type 2 diabetes and obesity. So when patients ask, how long do I need to be taking something? I tell them, as long as you have the disorder or the disease, I do not have a cure. We need to do our best with maintaining stability so that you have good health with minimal complications. So now that we've covered the groundwork, let's revisit Anna, our patient that we discussed and I introduced you to at the beginning. And this activity does include some helpful practice aids. And again, you're going to be able to download them from the PeerView website. But let me show you how I would use them to navigate patient-centered discussions to reflect Anna's needs and goals. So today, Anna is in for her first month follow-up with me since her initial diagnosis of type 2 diabetes. She's already been to see the dietitian and she's attended classes. Today, she's expressing concern that while her blood sugars have gotten better, they remain above the targets discussed of less than 120 and less than 180 after she eats. She said she's running anywhere from 120 to 130 before she eats, but it's really her after meals that are concerning her. They're going up as high as 210. And she's also upset that instead of losing weight, she is gaining weight. And she reinforces that she was really hoping to avoid medications. This was something that she mentioned in our initial appointment a month ago, which is why I said, okay, let's get you in to see a dietitian. Let's get you into some classes, and why I scheduled her appointment with me for a month later so that I could quickly intervene and make sure that she was doing okay. So these are her concerns, and now we need to address them. So this slide here is facilitating discussions with your patients about intensifying therapy for type 2 diabetes and weight. So I didn't mention Anna's weight, but most 42% of the adults in the United States have a BMI that's high enough to put them in the obesity category. So it would not be surprising that there was some issue with weight. So while I may not have mentioned it, let's say that she does have a BMI of about 32. So it's not just enough to address her blood sugars, but we also have to think of that comorbidity. On top of that, she's gained more weight. So I'm going to reassure her that the weight gain that she experienced is a natural phenomenon that we see when blood sugars actually get better. And so our goal is that with ongoing exercise that she has implemented and the significant changes to her diet, that will eventually even itself out as her glucoses improve, and hopefully she will start to lose some weight. But I am concerned, as is she, about her post meal elevations. So we'll talk a little bit more about what it is that she's eating, see if there's anything else that we can tweak. But this is where I am going to talk about type 2 diabetes as a disease process, not just focusing on the lifestyle management. And so, again, this is where I will bring up that ominous octet with her. And I will show her that outside of what she eats and the exercise she does or does not do, there are 8 pathological functions inside her body that are contributing to the hyperglycemia. And I can also going to show her some of the medications that we use for managing diabetes. And yes, I will include insulin in this discussion because I never want insulin to be made to feel as a threat or as a punishment. But we'll talk about what the options are, what the benefits are, and go on from there. And so hopefully by the end of that appointment, she's willing to do something in addition to taking a medication to help reduce her risk, to help get that A1C down, and help her live her best life. So before we move on, please take a moment to answer a question on your practice strategies. All right. So, in conclusion, and to summarize, that when you're starting that shared decision making process with your patient, please remember that there are some important things to consider. Not just the patient's point of view, but if they do have a support person in their life that does help them with activities of daily living or management of their disease process, whether it be helping them with meds, have them bring that person in because they can provide some additional insight. And keep in mind that we have tools available, not just for the patient, but also for us as clinicians to kind of help guide us through this process and to really strengthen our skills. And then making sure that we implement strategies that we feel comfortable with to get our patients participating in those shared decision making and understanding that those preferences and those limitations that the patient may have to be part of our consideration when we are developing that plan. We know there are many benefits to shared decision making, and probably the most important of all is the increased trust that the patient will have in us as their healthcare clinician, but also the trust that we now have in them that they are going to be forthright and, honest with what's going on in their life, regardless of what's going on in their life and how it may actually make them feel, that we are on their side throughout the process. So this concludes the formal part of my presentation for today. If you missed the first 2 office hours activities on prioritizing weight management and overcoming therapeutic inertia, please search for office hours on the peer review website to locate these activities. Now it's your turn. Please stay tuned and I will answer as many of your questions and challenging cases as possible. Hi, everyone. I hope you enjoyed the webinar. I am now here at your disposal for any questions that you may have, and I'm happy to entertain anything that comes to mind. So here is a question from someone by the name of Marge. How do you make the most of the little bit of time that we PCP tend to have in appointments when there is so much to cover? That is a great, great question. I think where shared decision making really comes in is when you have a patient that you have seen a few times and you can't seem to make headway with them. That would be the one that you really want to kind of lean in and find out where the barriers are. I firmly believe that every patient has probably more reason to not come in to see me than they have to come in to see me, meaning that, they may not have had their labs done. It could have been a really rough couple of weeks or a couple of months, depending on the last time I saw them. So the exercise that they plan to do went out the window. They haven't been monitoring their glucose or making the changes to their diet. And, a lot of patients feel shame and blame and tend to not come in for those appointments. And so when they're coming in, even if they didn't have any of that done, we're going to find some positivity. So the first thing is I acknowledge, hey, you've had a really challenging set of last X weeks, days, whatever. And I'm really glad that you kept this appointment, because we can figure out together where you are and where we need to move forward. And I think that helps to let their guard down a little bit, and then enables them to kind of let loose as to what has really been interfering. There are so many competing priorities that our patients have, that their health, oftentimes their health is the last thing that they will address, because they have so many other things that need to be done. A learner asked, how do you prioritize what needs to be discussed on follow-up appointment? Again, I may have my own agenda, but the patient also is coming in for a reason. So I always try to find out what brings them in for their appointment, other than the fact that we scheduled this follow-up at the last time that I saw them. But is there something that they need an answer to, or need to discuss, or have concerns about, that they must have before they walk out of my door? And sometimes that takes me off of the agenda that I think I need to cover. But if I don't address the concerns the patient has, I'm not going to get anywhere. So that's always a first start, because it's one thing to see a patient as a one-off, but our job as clinicians is not to constantly see new patients. It's to have those follow-up appointments, build that rapport and trust with our patients, so that we truly can work as a team. And so sometimes it means my agenda gets sidetracked a bit while I address the concerns that the patient may have. And then, saying, okay, we weren't able to really talk about your diabetes today, but I can see that unless we discuss this, that really wasn't going to make a difference. So would it be okay if we scheduled maybe a virtual appointment in a couple of weeks, where we can visit the diabetes that I wasn't able to discuss with you today? Or if you don't feel comfortable having them leave the office because of something that you were aware of from their glucose monitoring or their labs or something along those lines, making sure that you say to them, I also would like to make sure we talk about A, B, or C. And then knowing that there's going to have to be some time for both parts of that equation to be addressed. I have found that I can typically have a patient agree to a virtual follow-up if I'm unable to address the things. They're more than willing to schedule another appointment in that way if they can't come in. So another question is, how do you handle patient pushback when they are just refusing to move forward? So again, this is where trying to find out what the barriers are. So this actually happened earlier today. I was seeing patients virtually, and I had a woman who I was seeing whose A1C the last two visits has been above 8, about 8.5. And on the previous visit, not this visit, but on the previous visit, she really did not want to make a change to her medications. One of her medications is a GLP-1 receptor agonist, but she believes that she was losing too much weight. And so that's what I actually found out today. Really why she, the last appointment, she said, you know, I really haven't been doing great with my diet. It was the holidays. My father passed 2 years ago. It was a really rough month. Can I just have some time to work on this? And I said, well, I'm going to give you time, but I'm not going to give you 3 months. I said, so I need to touch base with you. So we had another appointment a month from the last time that I saw her. And she, again, you know, wasn't really as engaged as she was hoping she would be, blaming the weather, because it's freezing cold here in Maryland where I am at. It we've had wind chills at -4 degrees, if that's even possible. So I could understand, you know, not wanting to go out. Some people don't feel safe in their neighborhoods and they don't always think about doing things in the home. But that's where we said, I said, you know, let's talk about what's going on. Your A1C is just too high. Yes, changing your diet and getting into physical activity will certainly help. But in the meantime, while we're waiting or implementing these things, which do indeed take time to make a difference, you are experiencing damage from these elevated blood sugars. So I am wanting to help partner with you to really address what's going on so that you can live your best life with as few complications as possible. And that's when she told me that, you know, the easiest thing would be to increase the Trulicity that she's currently taking. But she's really afraid of more weight loss because her BMI is now 24. She started at a BMI of about 32, had made also lifestyle changes that kind of went haywire with the holidays and everything. So once I understood what her issue was with increasing that particular medication, then we were able to brainstorm other treatments that we could incorporate and bringing up the ones forefront that would not contribute to additional weight loss. And so we had our conversation about other medications that could be added that were either weight neutral. Some of them do contribute to some weight loss, weight gain, usually at higher doses. So talking about how we could mitigate excessive weight gain. And she was much more open then to trying something in addition to working on getting her lifestyle, her therapeutic lifestyle changes into place again. So, you know, finding out where and why the patients are hesitant to move forward is really important. And then that helps us to kind of explain where we are coming from to bring them on board. So again, it's about establishing that trust, that respect for the patient, what they bring to the table, not being judgmental in what they have to say, and really just listening. And sometimes during the course of letting them just talk, they can oftentimes formulate the solution or the bust to that barrier, and you can help formulate the strategy for them. Someone else has asked, how do we discuss side effects of meds that complicating with other meds? Well, I'm not sure how else you would do that, but just to lay it out there, what are the perceived benefit of a medication that you want a patient to be using? And, you know, what are the expected side effects? Are they something that can be mitigated? Are they something that are transient, meaning they won't be there forever? And how do we support them through that? And is there other, or are there other medications that they are taking that could pose a problem? And is it possible that the medication you are wanting to add could replace any of those other medicines? So it's going to take a little bit more information gathering from the patient to figure out really if the side effects are going to be something that are a go or a no-go for the patient, especially if there is a drug-drug interaction that is, going to lead to more harm than benefit. Any other questions? We have about 13 minutes. You have me for 13 minutes. So someone wants to know that I mentioned utilizing my medical assistant to help. How do you do this successfully? Well, it's going to take some training. So I work pretty closely with my medical assistant. I have one that is assigned to me. So that particular person knows, how I like to have things done and what I like to do. And so I trained her and said, when I am starting a patient on a new regimen, if I tell you they don't seem enthused when they're leaving the office, these are the patients that I need to have reach out for. I don't always have the ability to reach out to those patients. So I will have my MA, especially if it's a patient that perhaps is a little older, hearing impaired, maybe visual or dexterity is a concern. They need the support of a family member, but that family member didn't come in with them in that visit, which happens sometimes a lot. Reaching out within a week of that appointment with me to touch base and say, hi, I'm Miss Novak's medical assistant, and she asked me to reach out to you to find out how you are doing with the plan that you agreed and put in place at her last visit. Is there anything that you're experiencing problems with? Does your family member have any questions? And if they do and they're not there, is there a good time that we can call back so that they can let us know what they're experiencing? And I'm finding that even though that may take some time to contact the patient and get that information, that in the end, it actually leads to less anxiety on the side of the patient because they truly know that they're not alone. And that I am interested, invested in their well-being. And they are less likely to be those squeaky wheels that are frequently calling the office because they're frightened and anxious. And so that leads to that behavior where they're constantly reaching out. Sometimes they can appear to be angry or upset. They're rude to the front desk. I find that reaching patients and helping them out early after that appointment really does smooth the waters quite a bit and goes a long way to helping the next appointment flow even better. Someone else wanted to ask, how do you keep clean medical records, including diagnosis, list of accurate medication, and deletion the diagnosis and medication which are not accurate? So I have an electronic medical record, which makes all of that a lot easier. And so at every visit, my MA, when they're checking them in for their vitals, the first question they ask, has there been any change in your status, emergency room visits, procedures, whatever, since the last time Miss Novak saw you? And they will tell them the date that I last saw them, because sometimes patients don't realize how long it may have been. And also if any medications were added, changed, or discontinued since their last visit with me. And I make sure that they also know that that's not just pertaining to their diabetes medications. I need to know other meds for the same exact reason that the earlier question that was posed about drug-drug interactions. So, and then my MA will assist by cleaning out the medication profile, making those adjustmts while I'm seeing the patient. And then if there's a problem that's been resolved, I will go in there and resolve it if I know for sure that it's been resolved. So, an electronic medical record really makes all of that much easier. It still takes a lot of time, but it's not as burdensome when we were dealing with paper charts. And I really encourage my patients, especially when I see them for the first time, when I have them coming back in for follow-up, I tell them to bring every drug, supplement, vitamin, whatever it is that they take on a regular basis in the last 30 days to put in a bag. And then I also tell them, and if you have any medications that you have not touched in the last 30 days, put those in a different bag and have them come in with that at their appointment. And or they can come in and meet specifically with the MA, and she can make sure everything is updated. And if there's a question, I've often had patients where they might be taking atorvastatin and they have two pill bottles in there, and one is the brand name of atorvastatin and the other one is atorvastatin. Come to find out that they have been taking both because they didn't realize they were different meds. So if something like that gets identified, then I can get involved. But that's how I work on updating the record. How do you reconcile cultural or personal preferences that don't align with guideline evidence-based care? Well, that is a great question, because you know what? The evidence that we have is only as good as the evidence that we have. And the randomized control trials that and the meta-analyses and the expert consensus trying to get, even two endocrinologists to agree and yet get a room full is kind of crazy. But, all of that is based off of information that we have gleaned from our experience, correct? And unfortunately, the randomized trials that we have most of that information in don't include people of color often enough, typically not enough women. And it doesn't take necessarily, those studies don't take into consideration social determinants of health, cultural differences in approaches to self-management, as well as what they believe the role of the clinician is. And so we're taking data that we have gotten from predominantly white male and trying to apply that to every patient before us. And so I will urge you that while we strive to practice evidence-based medicine when we see our patients, we do need to keep in mind we don't always have all of the evidence that pertains to that patient. And the guidelines are merely that. They are guidance, and they're based on the information that we have. So it's going to, we're going to try to figure out, how does this work with our patients? And when you're talking about cultural differences, language differences, all kinds of differences that don't apply to those randomized control trials and the evidence that we have at hand, then that's really where you're going to be trying to involve all of the resources, a nutritionist perhaps that is fluent in that culture and knows those foods or health practices, if not to meet with the patient, to kind of help you to understand without necessarily stereotyping, because that's another risk that we fall into. But you bring up a great one, and it really is going to involve having communication with the patient, saying, tell me a little bit more about your culture. What do you typically eat every day? How do you celebrate this holiday? And that will help you to better understand and maybe to provide some recommendations, even though you don't feel that you completely understand how to do it. Getting their input will help you, and then getting the resources that you need is even better. So someone wants to know how to compare SGLT2 versus GLP versus tirzepatide, patient preference and adverse events. So the SGLT2 inhibitors and the incretins, which would be your GLP or your GLP-GIP, which is the combination, which is what tirzepatide is, they really shouldn't be compared. They're two very different classes of medicines, and they work very differently. And so it's really going to come down to evaluating the risk that the patient has and what drug might be more beneficial than the other, and then providing the options that you feel are appropriate. So, for example, if your patient comes to you and they have atherosclerotic disease, don't yet have heart failure, kidneys are a pretty good condition, then the guidance is to really push toward atherosclerotic disease risk prevention, and that's where the GLP GIPs have that stronghold. When it comes to kidney disease, heart failure, that's where the SGLT2 inhibitors really shine. But the good news is that the more studies that are being done, the more we find out. And so now we've got some data that even GLP-1s can help with renal function. So it really depends on the risk, on how you're going to phrase what the actual options are for your patients, as well as what else is going on. How high of an A1C do they have that you need to get them down? And will the drug that they prefer get them there? So an SGLT2 inhibitor at its best with an EGFR no less than 45 will drop an A1C of about 0.8%. And I say above 45 because we actually know that once the EGFR starts to drop below 60, it starts to lose its efficacy as far as glucose management. All of those other benefits for heart failure and kidney disease remain intact, but the impact on glucose starts to diminish. And so what we do know about the GLP-GIP is if you compare it directly to adding a basal insulin instead, that you're going to get as much of an A1C reduction with a GLP or a GLP-GIP combo as you would with basal insulin, but without the risk of weight gain and hypoglycemia and the additional benefits that these drugs bring to the table. So that's the kind of conversation that you should be having kind of with your patient, helping them understand what your thought processes are and why you really are inking toward one. And if they say, but you know what, I don't want to do an injection. Well, we do have semaglutide that's available as an oral option if it's covered. And so again, it's always prefaced on, well, these are the options we have if your insurance covers them and the out-of-pocket cost is not outrageous for you. So this is really good. Someone asked, does the MA have the knowledge to take care of things going in between visits? They are beyond their pay grade. Again, I work very closely with my MA. My MA is actually excited to be used to the top of her certification, and she knows when to come to me. She's basically just checking in. She's not giving any medical advice. She's not counseling the patient outside of what I expect her to be able to do. So she can certainly help if, oh, I don't check my blood sugars because it hurts my fingers, or, my sensor keeps falling off. And so that's why I haven't been wearing it. Or we look at their CGM data and they have a sensor that you need to use the phone or the reader to get the data. You have to actually scan it. And we're not seeing enough data, helping them troubleshoot through that. But if there are issues, she alerts me, and then that allows me to intervene much sooner. If I wait for patients to reach out, it's usually at the next visit that you find out that the medicine you started 3 months ago and asked them to contact you if there were any problems, they did not contact you, and they also either A, never picked up that medicine, B, started it for a day and decided it just wasn't something they wanted to continue with. And there was 3 months of, clinical inertia that happened, and I wasn't able to intervene. So again, it's working with your patients. So how are you handling the problems that arise when insurances stop covering medications that are working and there are no real good alternatives? How do you handle this discussion with the patient? Oh, that is a frustrating topic. I have less than 2 minutes to get through, and I don't know if I'll be able to. But I will tell you that is a very real problem, and it's something that is encountered almost on a daily basis with my patients. And so I tell them, look, we're going to do the best we can. If it's cost and they're eligible, I encourage them to look into the patient assistance programs, because a lot of patients actually do qualify because they have changed what they consider the poverty level, and that will allow them to get these medications for free. And so we're constantly brainstorming. I might tell them, you know what, this isn't the greatest option for you, but it is still effective. And while I might have to worry about hypoglycemia or something like that, I will be there to counsel them on why there's a risk for hypoglycemia if I have to use something like a sulfonylurea, how to mitigate, what we need to do if they ever need to be NPO or fasting for religious reasons or what have you. So, sometimes things don't work in our favor and we have to use those tried and true drugs, even though they don't have all of the benefits that these newer drugs have. They are affordable and we can make them work if we have to. I've seen significant weight loss with tirzepatide, but only slight reduction in A1C. They lose weight, they increase foods that they previously cut out of their diet. This is especially true for complex carbs. So this is where you really do need to get nutrition specialists involved, the dietitian, and having that conversation with the patient that, they're not getting all the benefit. I have 4 seconds. Thank you all so much. I wish you a great rest of your day.